Thank you so much, everyone, for joining us for today's Complex Pediatrics Echo session. We're doing this one in partnership with Dr. Huang from the Nevada Academy of Pediatrics and University of Nevada, Las Vegas. And I will turn it over to her.
Hi guys, thanks so much for joining us today. So my name is Betsy Huang. I'm the president of the Nevada chapter of the American Academy of Pediatrics. I'm a pediatrician in Las Vegas. And then with me today is Erica Marquez, and we are members of the Nevada Childhood Lead Poisoning Prevention Advisory Council. And that's what we're here to talk about today, lead screening. I'm going to share our PowerPoint presentation. Did that work? Can anyone see that?
Can't see it yet, no.
Let's try it again.
There we go.
Okay, perfect.
Perfect, yeah.
Okay, if there's any questions at any time, I think you use the chat function, and so you can just keep track and just let me know any questions I need to answer in between.
Absolutely, yep.
Okay, guys, so we're going to talk about screening children for lead exposure in Nevada and underestimated need. The objectives of today's presentation are to summarize the historical perspective of lead, describe possible sources of lead exposure, understand the effects related to lead exposure, understand the state of lead poisoning prevention in Nevada, and then implement lead testing strategies. So we're going to start with just a brief historical overview of lead. This is a timeline of some of the major historical events leading up to lead poisoning prevention, starting in 1973 with a lead gasoline ban. In 1978, there was a lead paint outlawed. However, more than 290,000 homes were built before 1978 in Nevada. In 1988, there was a plumbing solder ban, which lead pipe fitting solder is banned from drinking water pipes. And then in 1995, the Nevada State Health Division published an inconclusive study on the prevalence of lead poisoning in children. That was the first one of its kind in our state. In that same year, there was a canning solder ban in which the use of lead solders to seal food cans is banned in the US. In 2001, the EPA set standards for lead, dust, paint, and soil standards for the first time. And then in 2006, the CDC funds the first childhood lead poisoning prevention program in our state. And then in 2009, NRS 442.700 was passed, which encouraged providers to screen and report blood lead levels in our state. And then in 2015, the Department of Housing and Urban Development did fund a lead and healthy homes program in which it awarded $2.4 million to remediate and remove lead hazards in homes built before 1978 and address other healthy homes issues. That was started in Henderson, it's kind of ongoing today still. And in 2017, the CDC refunded the state of Nevada to develop the Nevada Childhood Lead Poisoning Prevention Program. And that's where we are today. Our goal is to increase the blood lead testing and improve the surveillance of children in the state with elevated blood levels and then link children to services. So let's talk about some sources of lead exposure. The primary source of lead exposure is where children live, which is in their homes. The likelihood of lead exposure is directly linked to the year of construction of the home. So if you look at this chart here, you can see that homes built before 1940, there's an 87% suspected of having lead-based paint, and then 68% suspected of lead-based paint hazards. Homes built between 1940 and 1959, there's a 69% suspected having lead-based paint and 43% suspected having lead-based paint hazards. And then homes built between 1960 and 1977, there's a 24 and 8% respectively. And then homes built between 1978 and 1988, there's a 7 and then a 1%. So as the years have gone by and, with the banning of lead paint and other items, the risk is less, but we should keep in mind that nearly 500,000 homes were built in Nevada prior to 1988. So the most common sources of lead exposure come in a few major areas. So the first one is lead paint in poor condition. There is lead dust produced from deteriorating surfaces. There's lead in the soil. That's from deteriorating surfaces. lead to gas emissions, manufacturing processes. We can find lead in water, primarily as a result of corrosion or wearing away of materials containing lead. And then you can have lead in the air through industrial processes and hobbies such as lead battery manufacturers. So here's some examples from Nevada of common lead sources. So you can see here's a home, kind of an older home. You can see the peeling lead paint in these two other surfaces. And then other sources of lead are what we bring into the home. So one of them is children's jewelry and toys. Lead has been found in inexpensive children's jewelry sold in vending machines in large volume discount stores across the country. You can have lead glazed ceramics, china, leaded crystal, and pewter. So lead may get into foods or liquids that have been stored in ceramics, pottery, china, or crystal lead in it. Lead glazed dishes usually come from other countries. You can have imported candies or foods, especially from Mexico, containing chili or tamarind. So lead can be found in candy wrappers, pottery containers, and certain ethnic foods. And then there's imported foods in cans that were sealed with lead solder. So in 1995, the US banned use of solder for our canned foods, but these can still come from other countries. And then mini blinds, so some non-glossy vinyl mini blinds from foreign countries can also contain lead. And then other common sources of lead include batteries, radiators for cars and trucks, and some foods or ink also contain lead. And then lead may be found in traditional and folk medicine, most often those used for arthritis, infertility, upset stomach, menstrual cramps, colic, and other illnesses. It can also be found in cosmetics and ayurvedic medications. So here's some samples on the screen. So Arzicon and Greta are used to treat upset stomach. Kohl and Surma are used in eye makeup. And then you can have Basma, Ayurvedic medicine used to treat and prevent health problems. This is mostly found in Southeastern Asian countries. Which leads us to workplace and hobbies that can also have exposure. So workplace exposures includes any contractors who renovate or repair homes built before 1978, workers who sand, scrape, blast lead-based paint, recyclers, sanitation workers around metal, electronics, or batteries, manufacturers of bullets, ceramics, electronics, or jewelry, firing range workers, gunsmiths, or police officers, military, construction demolition workers, boatswain and shipyard workers exposed to marine paint, mining, battery plants, lead smelters, bridge construction and repair, steel workers, automobile mechanics. You can also have lead exposure from hobbies. So some hobbies include shooting. You can have lead materials used in ammunition preparation, soldering. There's lead-based solder used in electronics. Stained glass pottery crafts. There's lead in the glazing, the paint, and the binding. And then fishing, some sinkers and some lures contain lead as well. You can see there's a variety of different ways that lead can also enter the home. Okay, so these are just some examples of non-traditional lead sources from our own states. So if you look at that vintage brass tea kettle, there's 14 parts per million. This vintage teapot is 13.6 parts per million. And these keys are 7,000 parts per million. More keys, 9,000. This imported metal pot is 43,600 ppms, which is quite high. And then this, there's one more. There's a ceramic plate that was 393 ppm. And then here's a tamale steamer, 367 ppm. This ceramic cup is 16,000 ppm. And then these shoes from a gun range worker, 66,000 ppm. Okay, so we're going to move along to who's most at risk. So as you can imagine, it's children. So children are most vulnerable. All children under 6 are at risk due to hand-to-mouth activity, their rapidly growing bodies, and then their exposure to traditional and non-traditional sources. Who's at greatest risk are actually children living in older housing and children who are low income or of ethnic minority status. And then more than 4 million American households have children that are exposed to lead hazards, and the CDC does report that as many as 500,000 children have blood lead levels greater than 5 micrograms per deciliter. Okay, so we're going to spend a few minutes talking about the impact of lead exposure to understand why this is so important. So the impact of elevated blood lead levels on the body, we're going to start at the bottom. So at 10 micrograms per deciliter, we start to see developmental toxicity, decrease in IQ, hearing, growth. There's placental transfer at this level. There's also impaired peripheral nerve effects. At 20 micrograms per deciliter, there's increased nerve conduction velocity, increased levels of erythrocyte protoporphyrin. at 30 micrograms per deciliter, there's increased vitamin D metabolism, increased risk of hypertension in adulthood. And then at 40 micrograms per deciliter, you have decreased hemoglobin synthesis. And then starting at 100 micrograms per deciliter, we see encephalopathy, colic, frank anemia, seizures, neuropathy, coma. And then if it's greater than 150 micrograms per deciliter, there's a risk of death. So some signs and symptoms of lead exposure. These are some things our patients might be complaining about when they come into the office. So they're all pretty nonspecific. So things like headaches, abdominal pain, loss of appetite, vomiting or nausea, constipation, seizures, weight loss, lethargy and fatigue, pallor from anemia, metallic taste in mouth, muscle joint weakness and pain, irritability. And then at low doses, lead exposure usually presents with no symptoms, which is part of the challenge and why screening is so important. So there's no safe level of lead exposure. There's no known threshold for effects of lead exposure. Lead poisoning does cause adverse health effects, including damage to the nervous system and brain, delayed growth and development, learning disabilities, decreased IQ and hearing damage, increased risk of behavioral problems. In extreme cases, it can lead to coma and death. And then in pregnant women, there's increased risk of premature and low birth weight newborns. Okay, so effects of early lead exposure on the developing brain. So children are more prone to neurologic deficits compared to adults. So we can see apoptosis, excitotoxicity, decreased cellular energy metabolism, impaired heme synthesis, oxidative stress, lipid peroxidation. There's an altered activity of secondary messenger systems, an altered neurotransmitter release and receptor densities, and then there's decreased brain volume in adulthood, which can be quite severe. Okay, so we're going to look at some studies that have been published looking specifically at the effects of lead exposure on patients. So this one is published in Pediatrics in 2006. It looked at the impact of elevated blood lead levels on brain organization and language. So for this study, they recruited 45 young adults with documented childhood lead exposure, followed them from birth to early childhood. So blood lead levels were drawn on a quarterly basis from birth to 5 years. So they had the subjects do a series of language tests and then had a concurrent MRI. So this on the screen is a composite of some of the imaging they had found. So one of their major findings is that there's activation in the left frontal cortex adjacent to Broca's area and the left middle temporal gyrus, including Wernicke's area. And they were found to be significantly associated with diminished activity in subjects with higher mean childhood blood lead levels. So diminished activation in these areas suggests that lead exposure during early childhood develops development of normative neural substrates of language. However, the authors did notice that observation that these subjects still use conventional brain circuitry indicates that the effect of lead exposure on neural substrates of language is significant, but not as severe as a traumatic brain injury such as a stroke. Then you can also see there's compensatory activation in the right hemisphere homologue of Wernicke's area that was enhanced in these same subjects with high blood levels. So the activation of the right hemisphere does suggest there's compensatory mechanisms at play. The brain is deploying new areas to replace lost capacity for language. And so there's, this is a hypothesis chain of events kind of leading to early lead exposure to adverse outcomes in childhood and adulthood. So what we think is happening is if there's childhood lead poisoning, this leads to reduced IQ, executive dysfunction, poor impulse control, difficulty with delaying gratification, which then leads to poor school achievement, high dropout rates, ADHD, conduct disorder, aggression and violence, and substance abuse. So this study is actually quite interesting. Once upon a time, we thought that if there were low levels of blood in the it wouldn't have such significant outcomes. This is a study that was published in Environmental Health Perspective 2005, and it specifically looked at the relationship between blood lead levels and IQ. And so this is actually a pooled analysis. So they pulled 7 international population-based longitudinal cohort studies, and they did statistical analysis comparing all of them. And one of their major findings is that the blood lead level between 2.4 to 10 micrograms per deciliter, there's a drop in IQ of 3.9 points. Between 10 to 20 micrograms per deciliter, there's a drop in IQ of 1.9 points. And then between 20 and 30 micrograms per deciliter, there's a drop in IQ of 1.1 points. So basically, they demonstrated that the steepest rate of decline is actually in blood lead levels less than 10. So earlier thought that the lower the level, the less severe the outcome is actually not true. It's pretty significant at all levels of elevated blood levels. This is another study that basically looked at blood lead levels and academic achievements. It was published in the American Journal of Public Health in 2013. So basically they looked at students in schools and compared their blood lead levels to kind of their proficiency exams in elementary school. So the authors did find a dose-response relationship in which the higher the blood level, the more likely the student performed worse across all areas in mathematics, science, and reading. And then this is another study that basically looked at early lead exposure and criminal arrests in early adulthood. So among 250 19 to 24-year-olds followed since birth, the likelihood of being arrested based on county criminal justice records was significantly associated with elevated prenatal blood lead levels, elevated blood levels at 6 years of age, and then elevated average blood level up to 6 years of age. And so the authors of this study concluded that there are probably multiple mechanisms at work. Lead interferes with synapse formation, disrupts dopamine systems, lowers serotonin levels. So lead exposure has been shown to reduce monoamine oxidase A activity. So consequences of these alterations could be neural dysfunction in areas involved in arousal, emotion, judgment, and behavior inhibition.
So just a couple of questions here that have come through. With so many uncommon causes of lead exposure, is it important to test adults as well as children?
Yes, it is important to test adults. However, I think what the studies are trying to show is that most of the effects, if children are exposed, the outcome probably is more severe and longer lasting. I think if we find that adults have certain behavior or neurological dysfunctions, lead testing may be part of their workup. Our goal is actually try to improve testing for children so that we don't need to these outcomes in the adults.
Mm-hmm. And then at low levels, can it transfer to a fetus?
Yes, at 10 micrograms per deciliter, it can be transferred.
Okay. And then are the IQ declines relative to the average general population or controlled for family IQs?
It was controlled. It was actually out of Detroit, the learning system. So they matched controls on similar socioeconomic status and family dynamic.
Thank you.
Oh, you're welcome. Okay, so we're going to move along to lead testing in Nevada, which is why we're here. So testing rates in Nevada, unfortunately, are quite low. We're currently at less than 3%. Current studies estimate that in Western states, including Nevada, 3 times as many children were underreported than were diagnosed. And some of the testing challenges in our state is that providers may not think exposure is a problem here in Western states. We do tend to have newer buildings, newer construction. I think if the mindset is that, oh, it's like older homes with lead paint, we may not have such an issue. But from some of the early slides, we do see that, quite a few homes here in the state of Nevada are older, up to 500,000 were built before 1988. And then the other challenge is parents. So parents may not understand why it's important to screen for lead. And then, if we're sending them to the laboratory instead of doing it on site, if we have that capacity, that's the compliance is not always secure. The parents have to go somewhere else, transportation, and, the kid might not want to be poked. So, there's twofold challenges we're trying to address so that we can get our screening rates up in our state. So ways to test for lead, recommendations for testing. So the CDC does recommend children are tested at 12 and 24 months of age as part of the well-child exam. And then, and if that hasn't been done at least once before the child reaches 6 years of age. Providers of children who are symptomatic or potential exposure to lead identified regardless of a child's age. And then there are 2 ways of doing blood lead testing. You could do a capillary or a venous system. So the venous one is where they get a poke at the lab. Some offices do have lead machines for an office where you could do a poke into capillary specimen. If we can get those in the office, in all offices, that would be great. It would certainly increase compliance by quite a bit if we could do it while the parents are here in their office. And then, we wouldn't be lost having them go somewhere else. Unfortunately, financially and how different offices work, that's not always possible, but that certainly is one way we can increase screening rates. And then if a capillary specimen does show a level greater 10 micrograms per deciliter, we do have to confirm it via a venous blood draw. And then testing is covered by Medicaid. It's usually covered by most insurances. So if you can't get one of those machines in your office, it would be reimbursed. So this is a childhood lead poisoning questionnaire. So it's adopted from the Illinois Department of Public Health. In Nevada, since testing rates are so low, we can't really determine local risk factors. However, based on other studies and state data, screening criteria have been developed to determine who should prioritize for testing. So a yes to any of the questions on the left should prompt a test. So is this child eligible for or enrolled in Medicaid, Head Start, or WIC? Does this child have a sibling with an elevated blood level greater than 5 micrograms per deciliter? Does this child live in or regularly visit a home built before 1978? In the past year, has this child been exposed to repairs, repainting, or renovation of a home built before 1978? Is this child a refugee or an adoptee from any foreign country? Has this child ever been to Mexico, Central or South American, Asian countries? Does this child live with someone who has a hobby or job that may involve lead? At any time, has this child lived near a factory where lead is used? Or does this child reside in a high-risk zip code? So a yes to any of these, it should prompt a lead screening test. So the Nevada Childhood Lead Poisoning Prevention Advisory Board, which Eric and I are both on, recommends that all children are tested because we're unable to identify at-risk populations in Nevada due to low testing rates and lack of demographic data reported with testing data. So zip code, race, ethnicity. This table shows basically what the recommendations are for lead testing and actions and follow-up. So I'm going to try to break it down. So in the first column is the blood lead test results. If that was drawn via a capillary assessment, the second column is when it should be confirmed with a venous blood draw. If the first value is from a venous draw, then obviously you don't have to confirm it. And then, so if the blood lead level is less than 5 micrograms per deciliter, basically we'll provide dietary and environmental education. We'll do environmental assessment of pre-1978 housing, and then you want to provide follow-up blood lead monitoring per the recommendations. Between 5 to 44 micrograms per deciliter, that's considered elevated. So you want to do a complete history and physical exam, additional blood work looking at iron status, hemoglobin, hematocrits. You want to refer to the health department for environmental investigation, recommend lead hazard reduction in the home, you want to do a neurological, behavioral, and developmental monitoring, and then get an abdominal x-ray if there's any suspicion of a lead ingestion. And then depending on the level, the repeat testing would basically be, once the levels start declining between, 6 to 9 months for the lower levels, up to like 2 weeks to 1 month for the higher levels. Between 45 to 59 micrograms per deciliter, this is when it's quite concerning. We want to do all of the above, plus additional lab work, including iron status, hemoglobin, hematocrit, and a free erythrocyte protoporphyrin level. This is when you want to start oral chelation therapy, and then consider hospitalization if a lead-safe environment cannot be assured. If the patient's going to be sent back home where the lead exposure is, that's not really going to be very helpful. So you would consider hospitalization at that point. And any patient with greater than 70 micrograms per deciliter, you basically hospitalize them for chelation therapy. And then you do want to get a consult with a medical toxicologist or a pediatric environmental health specialist. And then you would do repeat screening as medically, every 24 hours as medically indicated once you start the chelation therapy. Okay, so moving on to physical exam. So a physical exam of children with any blood level greater than 20 is recommended to determine whether the child has any signs suggesting encephalopathy, whether the child is engaged in high-risk behaviors, if the child has a behavior or neurodevelopmental disorder requiring a referral. And then the tricky thing is children identified by means of routine blood testing may have no remarkable findings on physical exam, which is why screening is important. So the role of medical providers, so our job. So according to a recent estimate, 12 to 16% of American children have developmental or behavioral disorders. The primary care—
Just a little trouble hearing you.
Okay, is that better?
Yeah.
Okay, So the primary care practitioner's office is often the only place where most children 5 and younger are seen, and this is the ideal setting for developmental and behavioral screening. And then really, we hope that we can help us improve the long-term outcomes for children in Nevada by making sure children are tested appropriately and the parents understand the significance of these testing and what the implications can be. So resources that are available, you can contact your local health department for resources available in your jurisdiction, and then select areas of Southern Nevada may qualify for remediation of lead hazards and no costs to both the owner or rental housing. Okay, so for more information, you can always contact Erica or myself. We'd be happy to provide any additional resources we can share. And then at this time, we'd be happy to answer any questions.
There was one question. Is the in-office testing CLIAA waived?
Oh, that's a good question. Erica, do you know the answer to that?
It is CLIA waived.
So yeah.
And any idea how much the machine costs to get?
They cost about, I believe, between about $3,000, and then the licensing is a couple other $100.
So I'm really surprised and kind of appalled at our low rate that we're screening kids. What do you think the barriers are in our state?
That's a great question. So we, well, Dr. Huang, you can also answer on this one, but we did do some initial work when we had the CLIP grant here in Southern Nevada to kind of assess why our screening rates were so low, and an assessment of some of our providers. The feedback was that they thought there was really not a problem here, and that was the perception. Like, it just, doctors aren't screening because it's not an issue. And that was kind of one of our biggest barriers, in addition to, parents wanting to take their kids for a blood draw if providers don't have a CLIA waive system on site. But the biggest barrier really is this perception that there is just an issue because we do have newer housing. So that's been our biggest challenge, is to kind of getting over that perception so that we can increase screening.
And I think the other part of the problem is actually the reporting. I think maybe more providers do screening. I think somehow isn't being collected in a central place.
That's true. We're hoping in the next year of our efforts is to get a better sense of providers that may have a CLIA waive system on site, that might just not be getting reported to us, so we're not capturing those kids that are tested. So that is definitely another issue that we're working on.
Okay, any other questions out there, please feel free to send them in through the chat function or take yourself off mute. And I have shared a screen with the post survey that we would like you to take as well, please.
Can you hear me?
Hello? A little bit, yeah.
Okay. So should we be screening older children too, over the age of 6?
Yes, if there's any suspicion, so basically any child that, the way I do it, is any child presents with any behavioral, cognitive, neurological, I'm sorry, that was a loud screech off my window, sorry. If there's any older children that you see in office that basically has any neurological, cognitive, behavioral issues, as part of what I do is I ask those questionnaires from the previous slide, and just a yes to any of them, I do a blood draw.
That'd be 50% of my adolescents. I mean, that have behavioral problems. Not to necessarily qualify in the questionnaire, but have
yeah, I think the questionnaire is a kind of quick and easy way to really, kind of stratify the risk. So we do see a lot of kids with behavior problems. If they really don't have any exposure to lead that we can identify in history, they probably may not need a lead, but the threshold is low. I would think if there's any suspicion at all, getting a blood lead level is something that's worth pursuing.
relatively easy, sure. So for reporting then, if this goes to the Division of Health, then does that division report to you, or are we supposed to be mandated reporters directly to you if we find a positive lead screen?
Question. So it depends in what part of the state you're in. For the most part, if you have a blood level above 5 micrograms per deciliter, which is the current recommendation for CDC for a response to occur, then that will get, if it's a laboratory test, that will get reported electronically to the state health division or locally to your health district. And then that information is aggregated for us to be able to report to CDC. If it's less than 5, or if it's a capillary done on site, that is now a little bit harder. In Clark County, you're supposed to report all blood level tests, regardless of capillary or a venous draw, and regardless if it's positive or not. That is not a requirement in the rest of the state. But we will be working over the next course of the next year to try to work with providers to help us get that data so that we get a better picture of what the problem is, and if there is a significant problem here in Nevada.
I don't want to hog with all the questions, but I do have one more.
Okay.
So, is there a Northern Nevada champion for this cause? Because I mean, Clark County is so big. You have your hands full. Is there someone up in the north who's helping to guide this up here?
Oh, absolutely. So we have our office that helps support the efforts here in Southern Nevada, and the Nevada Public Health Foundation is actually coordinating efforts in the north. And all of our health districts are on our advisory board across the state. So they help inform our process.
Any other questions? Please feel free to send them in, or unmute yourself and speak up. We'd love to hear from you.
I can give some insight as to why I was not testing kids at all, because when I first came to the Northern Nevada area, the previous pediatrician who worked with our clinic also said, the last time she saw an elevated lead level was so long ago that she's like, there's just no one who is being exposed to this, so I just stopped testing. And so then I took that as, okay, then I'm going to continue that. I don't want to expose a kid to more trauma than they need, and continued what she had been doing, which now I realize was not correct. But I kind of was going off of what previous experience demonstrated to her. So I know that that's why at least I wasn't, and I never saw it being done from my patients coming from somewhere else. So if they were a transfer patient from somewhere else, if I looked at the records, I never saw a level taken.
Yeah, and I think a lot of that depends on where you train and what you're used to. I did my residency in LA and we tested everyone. So when I moved here, I was like, oh, I mean, it was just a mindset to me. It didn't really occur to me to think about kind of demographically what the changes would be. But I think what you're saying is true. A lot of times it's what your office is already doing or what your partners are doing that kind of shapes your mindset. So our big goal is to really get the word out and to educate more providers and kind of discuss the significance of lead screening and really make it more of a commonplace practice.
I think me just being able to show patients or families, like, there's some really uncommon sources of lead that I didn't even know about that are in my own home. And so just because you think like my kid's not ingesting lead because there's no lead paint, that's what we commonly think, doesn't mean that your kid isn't exposed and there's no symptoms. And even at very low levels, they're not going to have maybe a symptom you can specifically see, but long term, we potentially could have a problem. So it's better to just screen them and know for sure that they're okay than just let it go, and then it becomes a behavioral problem or a cognitive problem later in life. But I just feel like I have better tools now to say, this is why we do it, instead of, well, you don't have lead paint, okay, you don't need it.
Awesome, thank you. That's great feedback.
Anything else out there before we wrap up? So there's a question about the slides being available. I will send out a link to our Project Echo webpage where those have been posted.
And feel free, please, to contact us if you have any questions about testing in your area or anything that we can do. Informational pamphlets or posters that we can post at your clinics, we would be happy to do that.
And you know, I'd just like to add, you can always visit the AAP, the Nevada chapter's website. We do have education materials up there, and we're trying to do more coordinated education efforts to our chapter as well. So.
Great. Okay. Yeah, if there's no other questions, I think we'll wrap up. Thank you so much, everyone, for joining us. Thank you, Dr. Huang and Erica, for presenting and fielding questions and everything like that. This was a great session, great information to get out there. So, yeah, thank you very much.
Thank you, guys. Thank you for joining us.